I'll take questions if you guys have.
I'll start.
Okay.
I know you're off to the airport this afternoon. I hope you're going somewhere warm, so we'll try not to keep you too long.
No, I'm going to New York. My parents are elderly, so.
More cold weather for you, I'm sorry.
It's supposed to be 59 on Monday, I think. So.
Okay, so it's not too bad, yeah. I think we're breaking 47 tomorrow, so. Better than where we're at now. I think I could pick your brain for a long time, especially with the MSC. I was a systemic, juvenile systemic arthritis person, now I have lupus. So I sort of am very fascinated by that. But are MSCs the thing that are sort of, I know they're an area of focus for you, but are they the buzz in sort of the research community and the stem cells? Is that sort of what everybody's excited about right now?
I think that there was a lot of excitement more a couple years ago, and now it's ramping up. So we were the first group allowed to go into early RA in this country, and now there's another company that has a trial design that looks very similar to ours. So I think in RA, people are a little bit skeptical.
Okay.
I don't think that's necessarily right. I think there's been a lot of interest in the pediatric community for a lot of diseases, because part of the problems, as you would know from having childhood arthritis, is that the toxicity over a lifetime is not from one medicine. It's from the disease, but it's not from one medicine, but rather cumulative use of many medicines. And so the CARA registry, or the Childhood Arthritis and Rheumatology Research Networks registry, is tracking children with all kinds of rheumatic disease. But the original was to do juvenile idiopathic arthritis, to ask and answer some of the natural history questions, as well as what toxicities might be associated with individual medicines. So in the lupus community, there's great excitement now with Gary Gilkison's trial, I think. It's hard for me to, I think people are cautiously excited, but feel like there are a lot of therapeutics out there that we have that are now very good, but not all people have access to them. At Metro, we're really fortunate in that we can really help people, even if they're uninsured or underinsured, to get medicines that they need. Go ahead, and then.
So we have a lot of support group leaders in this group, and so this is the boots on the ground, and sometimes questions come up of how do people get involved with clinical trials, and how do they know if they're a good candidate and stuff like that. Do you have suggestions on how to be aware and how to get involved?
So clinicaltrials.gov is probably the best site to know what's going on. Metro is going to have a research site that should have many of our clinical trials, and many of the other institutions do. I think probably we have the group of the academic centers. We probably are doing the largest amount of both sponsored and investigator-initiated research. Dr. Ballou has a trial going back into NIAMS for review that had some very good comments, and it's repurposing a drug that's used for something else to try and decrease persistent protein in the urine, especially for people who either can't take ACE inhibitors or ACE receptor blockers, or take them and they don't decrease the protein enough. Because part of what we've learned is patients with kidney disease have survived longer and longer, is that we used to think only of the glomeruli, or the units that filter the urine, as being involved in lupus nephritis, and they're usually the first hit. But over the long term, the surrounding matrix, or the tubular interstitium, also is probably responsible for a lot of the protein leak, and that happens in diabetes too. There's protein leak, and reducing that protein can help survival in kidneys. And so we're looking at an agent that could either be added to other things that exist, or could be standalone in patients who didn't tolerate the other immunoglobulin agents.
So,
Yes.
sorry. So, these are the boots on the ground people here, okay? So when they meet lupus constituents, what would we say to them to encourage them about being a participant in a trial?
So research match. So we, and we can sign you up at Metro. Suzanne has some cards. I can have people, if anybody emails me, they're interested in being involved in research match. So research match is a program where patients or healthy volunteers, so if you have healthy family members too who want to volunteer, that they can securely give their information to an organization that can then, when there's a clinical trial registered on Research Match that you might be interested in, they can then message you, are you interested, and you can find out more information by calling that. So Columbus has done a tremendous job at Research Match. Our CTSC is just ramping up with our effort matches, with our Research Match. There's always a little bit of a tension with institutions about how much do you want to be in a proprietary database that only people at that institution can see, and how much do you want to put out there so that you could go to any institution. And I'm actually involved in this conversation at the CTSC. How many of you feel like you wouldn't venture out of your own institution to, I just want to get a straw poll. How many people feel like they wouldn't venture out of their institution if there was a research study? It doesn't have to be interventional. Sometimes it's just observational, questions, blood, those kinds of things. Are there people who have strong feelings about it? Like how many people feel like they would venture out if there was something they were interested in? Okay, so about 60%, I bet, 60 or a little more. But institutions are very concerned about having their patients go to another institution for a research study, and that they won't come back, and that's probably largely not true. Go ahead.
Have you ever heard of the TC's by itself, NEP research? I go to the U of M, so I'm part of a research group there. That they take my kidney biopsy tissue, my blood, and urine.
So is Joe McCune running that?
I think so.
So Joe's my clinical manager. So was my clinical manager during fellowship. So he,
Actually, it's a female.
It's probably Emily something. So I trained at the University of Michigan. I spent 10 years in Ann Arbor.
So you know Michelle Calendar?
I do know Michelle. So Michelle.
She's my lupus specialist.
Okay, so Michelle was a MD PhD student at Case, and then did her residency in Cleveland. And when she was looking for fellowship, she actually asked me for a reference letter as I pushed her out to Michigan. And so we've kept in touch. She's a superstar.
Yeah.
And she was actually in Mariana Kaplan's lab, who I talked about. Mariana Kaplan was at Michigan and is now at the NIH. Yeah.
My question is more or less, when you go for a trial, you get accepted into it, how much, in a situation where you found doctors that you like, that I like right now that are treating my lupus in my situation, how does the team that you volunteered for, do they work with your doctors in the event that you have a reaction, you have something go wrong? That's my biggest
So I think it's easier within institutions. So when I came to Metro a little over 10 years ago, I said to people, listen, the way clinical trials enroll best are if we all put people in. And so there are certain investigators in our division who like to follow their patients into a clinical trial, and certain patients who will transfer care to that provider while they're in the clinical trial. And then sometimes they like that provider better, and sometimes they like their original provider better. I can really only speak to my experience at the institutions I've been at. When I was at UH, I was primarily Rainbow, but did adult clinical trials also. And most of those patients, I think, in peds would stay with their provider but in it, but in adult, they might switch temporarily and then go back to their provider. I think it's an open conversation between the doctors and the practice.
Okay.
But I think that's a realistic kind of thing. So I've had patients in Stan Ballou's trial, but I have patients in the RA trial, and if I'm not in town, he sees them.
But I mean, you guys don't cross, like, you have a trial at Metro. I go to Cleveland Clinic. I like my doctors at Cleveland Clinic,
Right.
but maybe this trial I'm a good fit for.
Right.
So I have very active lupus, I should say,
Right.
especially in the wintertime.
Yeah.
So what happens if that trial takes place during that time and I get sick? Is it, how do I say this? Is it a reaction to what I may have been given? I mean, how much does that information transfer to my doctor?
Well, it does. So, I think most of the rheumatologists in Cleveland know each other pretty well and aren't afraid to pick up the phone. Many of the clinic's faculty are on speed dial, or myself, and vice versa, because patients have insurance changes. Patients have all kinds of things where there needs to be communication, obviously with patients' permission. But I think that there is a responsibility of the research team to report if there's an adverse event or a serious adverse event. And so what usually happens is you'll get treated for whatever they need to do. Rarely we have to do something called unblind. So if you're on rituximab, and I'm doing a study with rituximab, or you're on any other prednisone, and I'm doing a study with prednisone. That's probably, that way we don't target companies. Prednisone, and I'm doing a study with prednisone. And you get admitted somewhere else because you got exposed to chickenpox. Never had chickenpox before and got chickenpox. This team that's treating you needs to do, it's always right to do what's necessary for safety. What's not clear, and it might be with prednisone that we would have to unblind if some patients were taking none, because if you're on prednisone and you get stressed, you might need more. So if that trial has a long-acting prednisone versus a short-acting prednisone, they're going to treat you the same way anyway, right? So they're going to give you IV steroids because you're stressed. If some patients are getting no prednisone and you're getting prednisone, at that point, sometimes what arm patients are on needs to be unblinded because they might have to get different dosing long-term, but we very rarely have to unblind. Basically, the principle is you do what's in the interest of the patient.
Okay.
And that, at least the responsible conduct of research. You do what's in the interest of the patient, and it doesn't really matter if you have a side effect where you get treated. If you're in my study, my study coordinator is going to ask you to sign a release of information when you come back to us so we can get all the records, because I would then be responsible for reporting its resolution, and trying to make attribution. So, do I think it was, if you get in if you are hiking and you fall on a rock and get a rock stuck in your knee and you have to go to surgery, arthroscopy to have it out, I have to report that as a serious adverse event because you've had unplanned surgery. But clearly that rock was because you're probably doing better and you were able to hike, not because of the prednisone I'm giving you. Right? So there's an issue of reporting, and there's also issues of attribution. So patient goes into a clinical trial, they've signed consent, they're just being screened, they don't even know if they're a candidate, they get their blood drawn and they pass out. And they have a history of passing out with blood draws. That clearly is an adverse event, but it's not related to the investigational agent that they've never gotten. But once you sign consent, anything that happens to you, you get in a motor vehicle accident because somebody, cut you off, you weren't even the driver. If you've signed consent, we still have to report that.
Okay.
So we're going to have to cut this short. We're going to have to invite you back because this was very invigorating for me and everybody else.
I thought I could pick your brain.